Our next speaker will be Dr. Silver. Dr. Silver is a professor of medicine in the Division of Neurology at the University of Toronto. He's currently the medical director of the Toronto West Stroke Network and head of the stroke program at Toronto Western Hospital. He's a past board member of the Canadian Stroke Consortium and past theme leader of the Canadian Stroke Network. He was a founding principal investigator of the Registry of the Canadian Stroke Network and is a co-principal investigator of the Ontario Stroke Registry. Dr. Silver established Ontario's Telestroke program and remains its medical director. Dr. Silver will be talking to us about stroke or TIA, whether it's real or imitation.
So it's always a pleasure, and it's always nice to come after the cardiologist because stroke was not always part of the Heart Association. It was the late Dr. Barney Barnett, who just passed away just a few months ago, who actually spearheaded the drive to get stroke in the name and make it the Heart&Stroke Foundation, and we've come a long way since that time. My talk today is going to be talking about those things that we deal with all the time in our offices. Is it real? Is it a pseudo event? Is it an imitation of the real thing? I'm going to get the slides to advance. I guess people are having trouble with this. Can we go to the next slides? So if you look at the typical TIA or stroke clinic, what you find is that a good majority of the patients that we get sent, they're having some sort of a spell, and we often call it the spells clinic because they're not really strokes or TIAs. So my job is to basically go through an approach to try to separate what's real and what's not. And if we can get the slides to advance, I don't have any disclosures that are relevant to this talk. And let's see if this will work. Good. Okay, so for those old timers that remember the typical television that had the vertical lock problem and you couldn't get the picture to work, and so you call the TV repairman, and typically what happens is the TV repairman shows up when the picture is perfect. And that's what we see every time we see someone with a TIA come into our clinic. They tell you a story about some disturbance with their vision or some transient weakness, but when we're seeing them and when we're examining them, they're completely normal. So it's very difficult to diagnose something that's now normal and there's no symptoms at the times or deficits at the time. So if we look at, get this next slide, please. If we look at what I'm going to do today is I'm going to try to talk a little bit about how to separate these mimics from the real things, and we'll talk a little bit of an approach to diagnose stroke and the importance of making an etiological diagnosis, a diagnosis that goes down to what's the actual underlying cause. Next slide, please. Why stroke is important and why it's part of this symposium is that stroke is common and it's the leading cause of disability. So as it's been referred to before, we often don't worry about dying suddenly of a stroke. We worry about surviving after a devastating stroke. But the important thing, and that's changed dramatically since I started, is that stroke is both preventable and treatable. Next, please. So this is what we worry about. This is on the one side, we see the large infarct that causes the patient to be aphasic and hemiplegic. On the other side, we see ultimately fatal intracerebral hemorrhage. So when we see someone with a transient or minor stroke, this is what we're trying to prevent, is that the next time they don't have one of these more severe events that can be devastating. So remember, stroke is really a syndrome. I often compare it for a cardiology audience to say someone's coming in with acute chest pain or an acute abdomen. All it's saying is that you have a patient that gives you a history of a sudden focal neurological deficit that we presume is vascular. And the key is focal. They have to have focal symptoms. But when we're dealing with a minor stroke or TIA, the symptoms have already cleared. So this is an example of a 61-year-old who had a sudden onset of right-sided facial weakness, arm weakness, and speech difficulties. Everyone will determine that that's something in the left hemisphere, probably MCA territory. But when we see the patient, they're back to normal. And in the old days, we'd say that's a transient ischemic attack, a TIA. But we now have the technology to go beyond the history. And if the symptoms persist for more than a few minutes, especially more than 10 minutes, and we do the appropriate imaging, this is an MRI scan with diffusion-weighted imaging that shows these bright spots. You don't need, you know, a neuroradiology 5-year training program to see them compared to the normal brain. They tell us this area of restricted diffusion means that there's infarction there. This is no longer a transient ischemic attack. This is a minor stroke. This patient's had a little infarct. And as we'll see, that becomes a great discriminator as to what's real and what's not. If you actually see infarction on imaging, it's obviously the real thing. So the way TIA has been changed is that we still have that same 24-hour rule, even though most TIAs are clearing, you know, within minutes. The difference is you also have to demonstrate that there's no infarction on imaging. So an approach to the patient is one that I actually developed when I was a first-year neurology resident, and I had to teach the medical residents about stroke. I said there's really 4 questions. Are you really dealing with a stroke? And that's the main emphasis of today. Is it a stroke or a mimic? And then the 2 famous neurological questions, where's the lesion, what's the lesion? And there's only 2 potential lesions. It's either an infarct or a hemorrhage if there is persistent damage. And then the most difficult is the last question is, what's the mechanism of the stroke? So let's talk about, is it really a stroke? And as you know, in life, there are things that appear to be the real thing, but they're not. And we can often go to Saturday Night Live to get these. So you remember Tina Fey and Sarah Palin. Just in case you think this is an old talk, I've kind of updated the slides to include Donald Trump and Hillary Clinton. So there are things that look like strokes, but they're not. Fortunately, many of the things in the past that were difficult, things like, is it a brain tumor or an abscess? Does the patient have demyelination? The imaging will help us, because once we've done the scan, we can see these things. Where we have difficulty are the things at the bottom, like functional sterical conversion, things like migraine and others. And this has been looked at systematically. This is probably one of the best papers of 1,532 consecutive patients coming to kind of a stroke clinic. And you can see there's various causes. You also notice that at least 1 in 5 of the patients turned out not to have a stroke or a true ischemic event. And if you look at the top 10 reasons, it's migraine, syncope, and we've heard a lot about syncope just a second ago, benign paroxysmal positional vertigo, seizures, functional disturbances, transient global amnesia, the lower motor neuron Bell's palsy, which you should be able to differentiate because they can't wrinkle their forehead on one side, peripheral nerve disturbances, postural hypotension, and tumors. And as we said, tumors are easy to separate. So the things that will help you differentiate whether it's a mimic or the truth is to, first of all, look at the pre-test likelihood that your patient has vascular disease. Do they have vascular risk factors, hypertension, diabetes, et cetera? What's the age of the patient? You can have a TIA or stroke at all ages, but obviously the risk is higher as you get older. The key is, was the patient describing focal symptoms? Focal means one side of the body, motor, sensory, speech like aphasia, that's clearly focal. A visual loss, that's a field defect, that's focal. But if the patient's just kind of generally weak and dizzy, that's not focal, or they're confused, that's generally not focal. So you have to find the focal symptoms, and if you're examining them, the focal findings. Features like motor and speech are weighed more than just sensory. I always say that, yes, someone that comes in with a numb thumb that lasts for 10 seconds could have had a TIA, but chances are it's probably benign and nothing to do with the cerebral circulation. Duration of symptoms is important, and we'll talk about how you use that to differentiate between migraine, seizure, and so forth. And then, of course, you should ask some pertinent negatives. Did the patient have headache, neck pain, chest pain, as we've heard a lot about, palpitation, shortness of breath? For seizures, one of the keys is the post-ictal phase, the confusion. And if you're dealing with a dizzy patient, do they have tinnitus, hearing loss, et cetera? So if we look at stroke, stroke is sudden. I often say it's like someone turned a switch on and the symptoms arise. So you're trying to get that sudden onset, and you should really pin them down to describe the history, not by just saying, yeah, it happened suddenly, but what were you doing at the time? Tell me second by second how the symptoms progress. Again, that has to be focal. The things that are almost never stroke or TIA are isolated symptoms like isolated dizziness or vertigo, isolated double vision, isolated sensory loss, or isolated memory problems. Those are almost never due to stroke or TIA. If you have one episode, we worry. You have two, that increases your angst a bit. But if the patient says they've been having this for the last 4 months and they've had, already 300 episodes, chances are that's likely benign because by now they would have had the big stroke. And then look for associated symptoms, as we said. So let's talk about a few of the common things. Well, first of all, migraine. It's very common in the population. Try to get a history of a family, that first-degree relatives, parents, siblings have also headaches. Usually starts at an early age, but the ones that confuse us are the late onset so-called migraine equivalents, the patients that in their 60s, 70s start to have the visual aura. But the key is that aura is usually a positive symptom. It's the shimmering, the zigzag line, the flashing. And one of the things I always tell my patients is when you get it the next time, and they almost always will if it's migraine, close your eyes, and if you still see the visual disturbance, it's likely migraine because it's a positive symptom. The symptoms also evolve over several minutes, typically 10 to 20 minutes, as opposed to sudden. And they can go from one modality to the next, like initially visual, then speech. And the whole duration is about 30 minutes. Give me some water. And then if we compare that to a seizure, seizures tend to be brief. So with a seizure, it tends to be only 1 or 2 minutes, and the longer phase is the postictal phase, and that's when you want to pin them down. What were they like when they came out of this blackout? And typically, if you have syncope, you wake up and you open your eyes and you're pretty much back to normal, unless it's prolonged. But with the typical seizure that's 30 seconds, when the patient wakes up, they're not initially normal. They're a little bit mixed up. They're kind of drowsy. They're confused. So that postictal period is the key to the history. And they might have a postictal paralysis that confuses things. They might bite their tongue. They might be incontinent. Ask about partial seizures. Do they get hallucinations of taste, smell? Do they get the déjà vu or the jamais vu phenomenon? And of course, you do the imaging, and the EEG sometimes is helpful. But remember, much like Holter monitoring, it only helps if they have seizure activity when they're hooked up to the EEG. If we compare the common 3 things that give you transient neurological disturbances, TIA, migraine, aura, this chart is sort of a summary in terms of the duration, the accompanying symptoms, whether it's positive, negative, etc. Next slide. So if we look at syncope, the only thing I'm going to emphasize here, because you've had a whole talk on this, is again the absence of focal symptoms. So it's very different if the patient says, well, I got vertigo, I felt a little unsteady, I had numbness down the right side of my face, my speech got dysarthric, and my tongue started to get thick. Yeah, that sounds like the prodrome of a vertebral basilar TIA, as opposed to typically these patients have no focal symptoms, they just pass out, and if they have a prodrome, it's a general feeling of lightheadedness. They feel they're generally weak, their vision is draining from them. Often patients tell me that it's like someone turned the volume down on the TV and their hearing starts to go and their vision dims. Those are not focal. That's because there's global hypoperfusion to the brain. One of the most interesting and amusing sometimes, but difficult ones are the functional patients, the patients with conversion. And those patients have 2 features that you should look for. Doesn't give you the diagnosis, but it suggests it. One is they almost always have a past history of a previous functional event. And the other is they get secondary gain. So you'd be suspicious if you find out that the person was due in court that same morning that they had their event, and this is their way to get out of it, or younger students that are missing an exam. There's usually some secondary benefit, even though the patient's not really aware of it. And the symptoms don't make sense physiologically. These patients are very suggestible. As you encourage them, they get better. You lift their arm up and they can't lift it, yet when you give them something to do, they reach up and grab it. So there's a lot of inconsistency. What's really helpful often is getting them off the stretcher and watching them walk, Yes, they'll limp and they'll drag their leg, but they'll be able to walk, yet on the table they can't even lift their limb against gravity. And of course, they don't have hyperreflexia, upgoing toes, etc. It can be difficult, and you sometimes need like an expert, a neurologist, to go over the findings. Beware of certain things that do fluctuate normally, like myasthenia gravis, where they can be normal now, and with fatigue they get weak. And they generally have normal imaging, of course, but we often try to make the diagnosis before we do the imaging. By far, dizziness is one of the great plagues of all of us. You know, William Osler's line was, when a dizzy patient comes in the front door, I sneak out the back. And when we see a dizzy patient, you say, okay, you're trying to differentiate, is there a hallucination of movement? Do they actually have vertigo, or is it just that lightheaded feeling, or is it even worse, you know, are they depressed or anxious and they just have that full feeling and the fuzzy feeling in their head, which is probably the commonest type of dizziness. It's very difficult to get patients to pin down what they mean, and we're sometimes just have to throw your hands up and you can't get a description. But again, they do not have focal features. They do not get double vision, slurred speech, facial droop. They don't have limb ataxia, and they don't have real gait ataxia. Now, the patient that has positional vertigo or acute vestibular neuritis who's very vertiginous, they're going to have difficulty walking, but they still usually can walk. And one of the mistakes that people make, especially in an emergency department, is you examine the patient on the stretcher and they do everything perfectly. Their strength's good, you know, finger to nose, all the things that we're taught in the neurological exam are perfect, but you don't really realize until you get them off the stretcher. They can't sit up because they have truncal instability, and then when you get them to stand, they really can't walk. And I've heard this over and over the years of how families said, you know, they had to carry their, you know, parent, you know, out of the emergency because they couldn't walk back to the car, even though the emergency physician examined them and missed the fact that they had, in this case, a cerebellar infarct that was causing their unsteadiness. Look for tinnitus, hearing loss, and recurrence over time, and obviously the fact that it's positional. Well, how often do we actually miss a stroke when it actually is just dizziness? Well, in this series of consecutive patients, they looked at 1,273 patients and followed them. Only 2% of the patients actually were diagnosed as having a true stroke or TIA at the time. And if you miss it and you call them, you know, non-stroke or TIA, you almost never get fooled that the patient comes back with a real event. Only 1% actually in a year follow-up had a stroke in follow-up, which was probably even just the normal baseline risk of stroke. So most of these cases with pure dizziness, they don't turn out to be strokes. Another interesting syndrome I love is transient global amnesia, because I can usually make the diagnosis from the description over the phone when the resident calls or the emerge doc calls. It's a sudden loss of global memory, and what's really unusual about it is it's not brief. This is the one that goes on for usually hours, and there's a point in the time where it starts and the patient has retrograde amnesia, so it's very similar to a concussion without the head injury. And then it might go on for several hours, but during that episode, if you actually examine the patient, the key is that they talk, they understand things, they recognize family. As you see from that little chart, they don't have any issue in identifying objects. They know what a pen is and they know what a watch is, but they can't remember anything. And if you show them something, you know, I typically will take out the $20 bill, show it to them, put the $20 bill under their pillow, and you distract them for literally 30 seconds and you say, what did I just show you? They have no memory of it. Or the classic example is they've just had a CT scan, they've just come back and you say, what test did you just have? And they have no memory of going for the CT. They have no ability to retain new memories, but it's self-limited, it stops and then everything goes back to normal. It's totally benign, we don't know what it is, but the only correlate is that there's a higher prevalence of migraine in these patients with TGA, but it's not a TIA, it doesn't pose a risk for stroke or dementia. And then, of course, we should do some metabolic toxic disorders if there are things like confusion and so forth. Remember, hypoglycemia, low sugar, can induce focal neurological motor signs, sometimes speech, so you have to make sure that you're not dealing with simply low blood sugar and check the usual extended electrolytes. Now, just to confuse things, there are the so-called, what authors have called the chameleons, the things that don't look at all like a TIA, which are really. And one of them is the capsular warning syndrome. This is the patient with the small, deep infarct that initially has wide fluctuations in their motor deficit. These are pure motor strokes. They come in with usually weakness down one side that can be severe, but it gets better. And then a half hour later, it's worse again, it gets better. You try to treat them, and they go up and down until they end either with a mild deficit or no deficit or severe deficit. They all have a deep, small infarct, usually internal capsule. That's why it's called the capsular warning syndrome. The limb-shaking TIAs, these are patients with hemodynamic problems. They have very poor perfusion. Let's say they have a critical carotid stenosis with no collaterals, and they stand up or they drop their pressure, and they actually their limb starts to shake like a seizure, but it's a limb-shaking TIA, sign of a hemodynamic TIA. Penducular hallucinations, pretty rare. These are midbrain lesions that give vivid hallucinations. Posturing, if you have brainstem ischemia, you can have shaking and extension that looks like seizures, but it's actually brainstem ischemia. Antons is where you've got bilateral occipital involvement. We see this most often from our cardiology colleagues in the cath lab, where they've given contrast or they've thrown an embolus up to the top of the basilar, and the patients confabulate, they look around, they pretend they can see, but they're totally blind. That's really a stroke, and I've seen even recently a medical legal case where the patient ended up on psychiatry because of their blindness until someone did a scan. And then the involuntary constant movements of hemibolismus, which is a lesion and infarct in the subthalamic nucleus. So the value of sorting these things out is if you have an index of suspicion that there's something more serious, do a scan. And now we're recommending in the guidelines that everyone that has what appears to be a stroke or TIA should have imaging, and we're not talking about just a plain CT anymore. If you think it's a TIA, they should have a CT-CTA in the emergency department, because not only do you get the parenchymal imaging, you can see whether they have an old infarct, a hemorrhage, but you can see the blood vessels and make sure that they don't have carotid disease in the neck or intracranial occlusion. Imaging is really, as we've said, great because we can diagnose an infarct. This is, again, diffusion-weighted imaging. Very easy to see acute infarction. It's positive almost immediately. We can also see by the distribution, these are multiple infarcts. This is almost certainly cardioembolic. And then even when we look at the old CT, it tells us a lot of things, and unfortunately I don't have the pointer, but this shows that there's an old infarct in the right hemisphere, which is on the left side of the screen. You can see that area of low attenuation. You can see in the Sylvian fissure there's a hyperdense sign, which there's clot within the middle cerebral artery. And what's really neat is that now that we do the angiography, it's all part of the first 10 minutes of their examination. You can see that there's a cutoff that on the right side, the proximal middle cerebral artery is totally occluded. So we know we're dealing with an acute stroke. This patient almost went back to normal despite this. And then there's some controversy of how do you treat it if they're neurologically normal despite the fact there's an occlusion. And you can see this patient has very good collaterals. They're getting lots of flow to that right hemisphere despite the occlusion. And we now in some centers have perfusion imaging. So this is a system called RAPID. It takes 2 minutes once the image is sent to the box to give us these multiple color maps, and we can see in the right hemisphere there is a large area with decreased perfusion, and that's the reason the patient had their symptoms. Well, how do we put this all together? I have a couple of minutes to finish off. Well, this started the whole trend of how to triage patients with TIAs, and this is Claiborne Johnson's seminal work that was published back in 2000, looking at a consecutive series of 1,700 patients with TIA and following them to see what happened to them. And what he showed is that if you looked at certain risk factors, you could predict which ones were going to go on to have a stroke. And the ones that were most predictive were motor weakness, speech, symptoms greater than 10 minutes, the presence of diabetes, or age. One of the mistakes people make with these scales is that if you start with diabetes and age and you're dizzy, you get 2 points right off the bat. That doesn't mean this patient can be used in this scale. They first have to have the focal deficit, the TIA, and then you add the factors to see whether it's likely they're going to have a recurrence. And what they found in this series is at 90 days, 10% of them had a recurrent stroke, and half of them had occurred within the first 48 hours. And that's where this scale you've already heard about, the ABCD2, evolved using age over 60, blood pressure over 140. Features of a TIA, you get 2 points for motor, 1 point for speech. And then duration, you get 1 point if it's from 10 to 59 minutes, and 2 points if it's more than 60 minutes, and diabetes. And you can see that if you have, it's easy to get 6 to 8 points. That suggests that you have a very high risk, an 8% chance of having a stroke within the next 2 days. So this is useful. What extended the scale is to actually do the imaging and say, what if we do an MRI and we actually see an infarct? That even further increases the risk. So if you have an infarct and an occlusion on your scan, you have a 32% chance of having a stroke within the next 30 days, which is pretty high risk. We've gone even beyond that. There's a lot of controversy of the original scale. They've added things like positive diffusion, carotid stenosis. So there is actually an ABCD3I scale, which no one uses. But it says that all these things help us differentiate which is real, which are not. I'm going to finish by just showing 2 concepts here. One is that if you look at recent data, this was just published in the New England Journal in the last little while. If we go back 1 slide, we see that if you look at factors as the cause, that will help differentiate the patients at risk. But what they found is in the modern times of actually, after you've done all the workup, that you've reduced the risk of recurrence by 50%. So rather than it being the 10% risk in the first 90 days, we're down to 3% with appropriate investigations. Next slide. And doing the workup makes a difference. This is data that came from our registry. Maura Caprell was the first author. And it shows that if you admit the patient or you work the patient up, you reduce the risk of recurrent stroke by 50%. So the patients that had the worst outcome were the patients that were sent home from the emergency without appropriate follow-up. So again, the key is to make the right diagnosis. In terms of etiology, we do further investigations, and that's where we start looking at the blood vessels, the heart, and the blood, and we do these investigations because what we're trying to do is find out, is it cardioembolic, is it large artery atherosclerosis? That will determine whether we treat the patient with antiplatelets, we treat with anticoagulants if it's cardioembolic, and whether the patient has carotid disease that might require surgery or stenting. But all of the final part, which is obviously an entire new talk, can be found by just going to this website, which is www.strokebestpractices.ca. Everything you'd ever want to ask about every aspect of stroke care is there. We probably have the best guidelines in the world for stroke, thanks to a lot of efforts from the Heart&Stroke Foundation. So I will end there, and I guess we have an opportunity for questions.
We do. We're just